Good afternoon. Thank you, Dr. Vikas. Thank you, Dr. Prabhat, for giving me this chance. I'll be discussing a very common topic. I'll be brief about it regarding the management of chemotherapy-induced anemia and what are the possible, treatment options, the role of iron therapy, ESAs, and blood transfusion. So there are three basic mechanisms of anemia. First is the direct effect of neoplasm, that is bleeding from tumor or bone marrow infiltration of the tumor. The second is an effect of a product of neoplasm like autoantibodies leading to hemolytic anemia, microangiopathy, amyloid production, cytokine inhibition of erythropoiesis, and paraneoplastic pure red cell aplasia. Third is the treatment effect, that is chemotherapy or radiotherapy. So there are three main modalities of treatment of chemotherapy-induced anemia. The first is iron therapy, which can be oral or parenteral. Second is blood transfusion, and third is ESA, that is erythropoietin stimulating agents. So coming to iron deficiency in cancer patients, so there are two basic type of iron deficiency. First is the absolute iron deficiencies, where the total iron body stores are very low. Second is the functional iron deficiency, that is iron sequestration related to inflammation, in which hepcidin mediated iron block renders the iron not available for erythropoiesis. So you can see in this figure that absolute iron deficiency anemia is mostly because of blood loss, either GI bleeding, hematuria, or vaginal bleeding, or it's because of poor iron absorption, ultimately leading to depletion of iron stores. And functional iron deficiency anemia is because of the inflammatory process related to cancer and chronic inflammations, in which various cytokines like interleukin 6, interleukin 1, and TLF alpha are produced. And in liver, there is hepcidin and the iron sequestration, which is related to inflammation, in which hepcidin mediated iron block is there. So that ultimately leads to functional iron deficiency. So the prevalence of iron deficiency and anemia is very common in various types of tumor. Around 40 to 60% of all solid tumors, they have iron deficiency or anemia. And around 50% of hematological malignancies, they have anemia. So how do we evaluate for iron deficiency? Is we do an iron panel, which includes transferrin saturation, serum iron level, ferritin, and TIBC. So based on these values, we can classify which type of anemia, iron deficiency anemia, we are dealing with. Absolute iron deficiency means that ferritin is less than 30 nanogram per ml, and the transferrin saturation is also low, that is less than 20%. For this, we need to replace iron and periodically assess. And the functional iron deficiency is there in patients receiving ESAs. The ferritin is high, that is 30 to 500 nanogram per ml, and the transferrin saturation is less than 50%. So in this, IV iron supplementation can be considered. And if there is no improvement in HB, then ESA can be given. Third is possible functional iron deficiency, where the ferritin is high, more than 500 to 800 nanogram per ml, but the transferrin saturation is less than 50%. So usually no iron supplement is needed. You can give a trial of IV iron, and if the HB does not improve, then ESA can be given. Third, when there is no iron deficiency, that is with a high ferritin of more than 800 nanogram and transferrin saturation of more than 50, there is no need or there is no benefit of IV or oral iron. So difference between oral versus parenteral is that oral iron requires compliance for several months to be effective. There is usually poor tolerance because of the GI effects and metallic taste, and the absorption is challenged, especially in cancer patients, because of various reasons like bleeding and inflammation. Whereas parenteral iron, it is a better modality to use because it bypasses the issue of compliance and gastrointestinal tolerance, and it bypasses the intestinal hepcidin ferroportin pathway that controls the iron absorption. It reduces the pill burden, and there is a faster HB increase and more efficient replenishment of iron storage. So there is some data that suggests that iron therapy can be helpful and can lead to increase in HB levels. So in this slide, you can see that this was published in JAMA Oncology. So in comparison with no iron supplementation, adding iron to ESA results in fewer patients receiving blood transfusion. There was a beneficial effect of iron supplementation as an adjunct to ESAs compared with ESAs alone on mean change in HB levels. And the trials which have been using IV iron supplementation showed evidence for a difference compared with trials using oral iron supplementation, and the benefit was more with IV iron of 0.84 gram per DL. There was no evidence for a difference in risk of thromboembolism events. So the summary of clinical trials on chemotherapy-induced anemia using intravenous iron with ESA. So you can see that there is no benefit of iron in most of the studies. However, re-analysis of the trial data indicated that trial participants who received at least 80% of the planned IV iron dosage had a hematological response similar to participants in the other IV iron trials. So what are the various iron preparations that are available? Low molecular weight iron dextran, ferric gluconate, iron sucrose, ferric carboxymaltose, which is the most commonly used that we generally use in our clinical practice. And the dosage of ferric carboxymaltose is that 750 milligram IV for patients weighing more than 50 kg, and the dose can be repeated once at least 7 days later. Total treatment course is around 1500 milligram. Or it can be weight based also. If the patients weigh less than 50 kg, it is 15 milligram per kg body weight, and the repeat dose once at least 7 days later, and the total treatment course should not exceed 1500 milligram. The other iron forms, they are not presently available with us. Even the NCCN guidelines and the ESMO guidelines recommend that iron deficiency should be treated with the iron. And now coming to the blood transfusion part. So basically there is no specific level of HB which acts as a trigger to start transfusion. So it depends on the symptoms of the patient, the intent of the treatment, whether it's curative and palliative. So NCCN considers the rapidity of HB decline, associated comorbidities and physiological symptoms, which decides the need for giving blood transfusion. So if the patient is not symptomatic and without any significant comorbidities, we can observe and we can avoid transfusion. And if the patient is high risk, that is progressive decline in HB with a recent intensive chemo or radiation, or the patient is not symptomatic but is having cardiac disease, pulmonary diseases, vascular diseases, then blood transfusion can be considered. Or if the patient is symptomatic, like with tachycardia, tachypnea, chest pain, dyspnea on exertion, syncope, severe fatigue, then transfusion can be considered. So usually the threshold for giving transfusion in curative setting, because we have to complete the treatment plan and maintain the dose density, the threshold is slightly less in curative setting. So there are various guidelines which help us to recommend the need for blood transfusion. The American Association of Blood Banks recommend maintaining HB of more than 7 grams in hemodynamically stable hospitalized patients. And in patients with a pre-existing cardiovascular disease, HB should be, if the HB is less than 8, then transfusion should be considered. And obviously, depending on the symptoms, the need for transfusion should be decided. And the ESMO recommends transfusion in patients with HB level less than 7 to 8 with or without severe anemia-related symptoms. And the NCCN recommends transfusion of patients with symptomatic anemia and monitor the patients with asymptomatic anemia who lack significant comorbidities. And to consider transfusion in patients who are at high risk with progressive hemoglobin decline in the setting of recent chemoradiation. So red blood cell transfusions are indicated in patients with cancer who are hypovolemic and refractory to fluid resuscitation, especially in the setting of blood loss. Patients with cancer and chronic symptomatic anemia who are not responsive to iron supplementation, and patients with cancer who require rapid correction of HP. So it remains controversial whether or not improving HB by blood transfusion improves the treatment response. So it's all based on the clinical scenario and the judgment of the treating physician, and obviously the intent of the treatment and the rapidity which we want the anemia to be corrected. So there is this Indian data which is showing that because of decreased HB or anemia, there can be a delay in treatment and which can cost an addition of 7,000 rupees to the patient. So determining the cost and time delay associated with transfusion requirement in Indian patient with non-metastatic breast cancer on dose-dense pre-operative chemotherapy was the purpose of the study. And they found that nearly 1/3 of the study population had a delay between 2 cycles because of chemotherapy due to anemia, and a median additional cost of 7,000 occurred because of the need for blood transfusion. So that means that the blood transfusion also comes with a increased risk and increased cost. So the possible risk of red blood cell transfusion includes transfusion reactions like hemolytic, like hemolysis, fever, non-hemolysis, lung injury, transfusion-associated circulatory overload, the risk of infections, and iron overload, increased risk of thrombotic events, and possible decreased survival. And there is also risk of increased alloimmunization. So allogenic blood may induce a thrombotic as well as an inflammatory responses. And this Cochrane review of 2012 showed that blood transfusion for anemia in advanced cancer showed a significant increase of HB levels and a subjective symptomatic response rate. And patient survival varied greatly, ranging between 2 and 293 days, and a high percentage of patients, 23 to 35%, were dead after only 2 weeks from transfusion. So basically, it means that as far as possible, we should avoid transfusion, but you should use other measures of correcting anemia, like treating the deficiencies and giving ESAs. So there is this retrospective analysis of venous thromboembolism trends in chemotherapy-induced anemia and red cell blood transfusion versus ESA administration. So in this analysis, around 10,000 odd patients with chemotherapy-induced anemia, around 76% did not receive any therapy, and 2,008 patients received blood transfusion, 246 patients received ESAs, and 137 patients received both. So 25.7% developed a VTE within the 90-day period, and VTE risk following RBC transfusion was more than twice the risk following ESA administration. There is statistically significant increase in VTE following RBC transfusion in patients with colorectal cancer, cancer of the bone marrow, and head and neck cancer. So blood transfusion has its own benefit and demerits. That is, it increases the risk of VTE, which is more as compared to ESAs. Okay, so role of erythropoietin in erythropoiesis. So that is the last part of my presentation. So erythropoietin promotes of mature RBCs in bone marrow, and more red blood cells in circulation leads to increased oxygenation. And erythropoietin is essential for terminal maturation of erythrocytes. Erythropoietin rescues neocytes from apoptosis, and it helps to sustain RBC proliferation and differentiation. So we have short-acting and long-acting ESAs. Short-acting includes epoietin alpha, and long-acting is darbepoietin alpha. So ESAs have shown a better hematological response and decrease in the need of transfusion risk. So considering all the ESA trials, pooled effects indicate that these agents improve HB and result in fewer transfusion. In terms of health-related quality of life also, so there is a treating to high target HB levels of more than 12, it is accompanied by improved health-related quality of life. So when to administer ESA? So ESA therapy is recommended in patients with symptomatic anemia who receive chemotherapy or combined radiation chemotherapy and present with an HB of less than 10. It may be offered to those patients with chemotherapy-associated anemia whose cancer treatment is not curative in intent and HB is less than 10. So this is the slide showing dosages that I'll skip. So again the dosages slide that I'll skip. So there is a risk of thromboembolism, and with ESAs also. So randomized trials have shown a risk of 50 to 70% increased risk, and special attention should be given to those patients who have multiple myeloma or being treated with drugs which can cause increased risk of thrombosis. So I'll conclude my presentation. So I just want to state that there is some recent evidence. There is Indian data that has also shown that adding ESAs to anemia patients can result in better treatment outcomes and better quality of life. And the most frequent adverse events that was reported in the Indian study was hypersensitivity reaction, and the risk of embolic and thrombotic events were 1.6% and 1.1% respectively. So the important thing that I would like to highlight is that recommendations against the use of ESAs. So ESAs presently are, not recommended in patients who are receiving myelosuppressive chemotherapy with curative intent, like early stage breast cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, etc. And patients with cancer who are not receiving any therapy, and patients receiving non-myelosuppressive therapy. So there is not enough evidence to use it. So this is my last slide. So we have three modalities to correct anemia: the ESAs, iron, and blood transfusion. All of these have their own risk and merits, and we have different clinical scenarios. So the first way to go is correct anemia. If the HB does not respond to IV iron, then the next is ESAs. And if you need a rapid or a symptomatic patient, then blood transfusion is the way to go. Thank you.